Hello, my name is Alok Shah, a fourth-year anesthesiology resident at the University of Washington. The multidisciplinary transfer of care represents an error-prone process during which vital information can be lost or altered. Multiple studies have determined associations between substandard transfers of care and patient outcomes. A culture of safety survey at Harborview Medical Center demonstrates an emphasis from providers and staff to improve transitions of care, and clinical experience in the recovery room is evidence for these responses. For instance, the representative from the surgical team was not required to be present for the handover. There was no electronic health record documentation of the handover, which is often taken down on scraps of paper. A multidisciplinary group of perioperative healthcare providers undertook a pre-post implementation analysis to study the effect of an intervention package on the quality and accuracy of the post-operative transfer of care report at Harborview Medical Center. The intervention package consists of a visual checklist governing the order of the handover as well as the specific information items to be discussed. The second intervention is a new electronic health record document that is completed by the recovery room nurse concurrent with the verbal handover. The third intervention calls for the surgical resident to be present for the post-operative transfer of care and stay until the end of the verbal handover. Our specific outcomes included the attendance rate of the surgical service representative, information reporting rates using the electronic health record as a comparative gradebook, and balance measures including handover duration. During the pre-intervention phase, we employed 2 independent trained observers to conduct in-person observations of post-operative handovers. 2 independent auditors also reviewed the entirety of electronic health record for each individual audited patient and collected information on the same variables. Matched reporting, defined as the correct inclusion or omission of information items based on the corroborative information in the electronic health record, was calculated for individual items. Pre-intervention results are summarized on the following slides. Surgical resident presence was only noted in 57% of the audited handovers. The average handover duration was 3.2 minutes. Severe deficiencies were noted with anticipatory guidance measures, including plans for continued pain control and call triggers for specific concerns. Virtually no one leaves their contact information for the RN should there be any emergencies. There were several deficiencies in the reports of both surgery and anesthesia providers, including discussion of antibiotic and paralytic medication redosing, pressor use, and prophylactic antiemetic use. Nursing perceptions were consistently positive for different qualitative domains of the handover. This discrepancy was the information reporting rates, is suggestive of the familiarity between the perioperative staff and healthcare providers. We are currently in the post-implementation phase, which began on March 15th, and will be collecting data until October. However, we will be mandating the use of both interventions starting July 1st. In the interim, we conducted an electronic focus group with every surgical chief resident of every service to garner several responses and revisions to the checklist. A similar process occurred for the electronic note. RN shift champions were selected to encourage adoption of the revised workflow. Educational initiatives, including an instructional video demonstrating the revised process, are made available through QI and administrative meetings and the department intranet.